Ophthalmology for giving me the opportunity to present two cases. I call these two cases as the brain ticklers because it will stimulate you for thinking what could be the diagnosis. So keep your thinking hat on. Case 1, a 66-year-old male who had vision right eye 6, and 6, left eye 6/18, and these two nodules are there in the choroid. And in fact, 3 nodules are there in the choroid. What could be the diagnosis? The patient was smart because he was elderly and he get the PET CT scan. He did not wait for anything. And the PET CT scan did not really help him. It showed 2 non-calcific nodules on the right middle and the lower lobe, showing mild increased metabolic activity, suspicions of the lung metastasis. At the same time, it showed metabolically active multiple lymph nodes in the right paratracheal, subcarinal and bilateral hilar and paraaortic region, and suggestive of inflammatory pathology. So these nodes are active. Investigations, they go ahead and did the bronchial brush and was negative for malignant cells, and histopathology showed granulomatous etiology. MRI brain was normal, and the OS-OCT showed serous elevation of the neurosensory retina. Routine blood investigations was normal. ESR was raised to 38 mm. Serum angiotensin converting enzyme was remarkably raised, and it was 81 international unit. MAN2 was negative, particular TB gold test was negative. Now the diagnosis is easy. Ultrasound showed a nodule in the choroid with the secondary retinal detachment, and angiogram showed early hypofluorescence and late hyperfluorescence. What is your diagnosis now? No? Sarcoid is the diagnosis. So the differential diagnosis in these cases, one need to, though the diagnosis is sarcoidosis is obvious, but when you see for the first time clinically, you need to keep the differential diagnosis of sarcoidosis, tuberculosis, particularly in an endemic country like India, and metastasis because the patient was an elderly patient. But with the investigations of serum angiotensin converting enzyme normal and bronchial brush HP showing granulomatous etiology, we treated the patients for the steroid sarcoidosis on oral prednisone 1 mg per kilogram of the body weight. And let's see what happened. It showed remarkable resolution of the lesions on ultrasonography. And also clinically, we could see that the lesions at 2 weeks and at 4 weeks showed significant resolution as it does in case of sarcoid. And at 3 months, vision becomes 6/6. The serous elevation of the retina was gone and the lesions become flattened and started pigmenting. So, are you underdiagnosing sarcoid uveitis? Like nodules, like in the choroid, solitary or multiple, optic nerve head granuloma, that this case was also presented. We treated with the IV of prednisone and subsequently methotrexate. And candle was dripping, as you see in case of retinal vasculitis in sarcoidosis. So sarcoidosis should be suspected in solitary or multiple choroidal nodules, optic nerve head granuloma, retinal vasculitis, intermediate uveitis, granulomatous or non-granulomatous etiology, anterior uveitis. Non-granulomatous anterior uveitis can also present as sarcoidosis. And in all these cases, sarcoid has to be ruled out by doing the enzyme estimation, serum angiotensin converting enzyme, a CT scan of the chest, and quantiferon TB gold test and MAN2 test by getting its negativity. What's new in the sarcoid? The recent publications, they found that the CD4-CD8 ratio of vitreous fluid is of high diagnostic value in sarcoidosis. This came in the Ophthalmology 2012 from Japan, and they found that CD4-CD8 ratio of the vitreous in lymphocyte has a high diagnostic value in ocular sarcoidosis compared to the CD8-CD8 ratio in the bronchial fluid of lymphocytosis and pulmonary sarcoidosis, which you do routinely. Case 2 is also a quite interesting one. A 23-year-old male complained of dimness of vision in the left eye for 45 days. No history of trauma, no history of any other ocular complaint, no history of any systemic illness, no previous ocular or systemic surgery, afebrile, no lymphadenopathy. CNS patient was conscious, cooperative, well oriented in time, place and person, because I'm telling it because if you see that anterior segment finding, the vision was quite less in the affected eye and vitreous cells was there. There was no KPs and the cornea was clear, pupil was normal. But what we found in the fundus, a mass lesion in the fundus with serous retinal detachment. What is your diagnosis? Any thought? TB. TB is a thought, and in fact is that there was a serous retinal detachment, and this is a montage photograph. And this ultrasonography showed retinochoroidal mass lesion, inferior quadratic, abutting a optic nerve head with high surface and moderately internal reflectivity, acoustics following, mild choroidal elevation, height was 7.1 mm, basal, horizontal 13.5 mm, epidiameter was 13.8 mm. Surrounding this, there is a detachment involving the inferior nasal quadrant, inferior temporal quadrant, and inferior quadrant. No posterior back shadowing or extraocular extension, retina at elsewhere. Rest of the choroid and optic nerve head shadow normal. With the basis of this kind of mass lesion, we did the investigations. Mantoux test was positive, but Mantoux test is positive in majority of the Indian individuals, healthy individuals, so we did not make that much value, but this case is correlated with the positive Mantoux test. Quantiferon TB gold test was positive, HSCT test was normal, MRI of the brain and orbit was normal, fundus photography, ultrasound, biomicroscopy, and fundus fluorescence angiogram was done. Fundus fluorescence angiogram showed early hyperfluorescence with late leakage of the dye. So differential diagnosis was a choroidal, a subretinal abscess, choroidal tuberculoma, but it could be a toxocaral, lymphoma, choroidal metastasis, amniotic choroidal melanoma. These are the possibilities was also kept, but first was on in our mind was a choroidal subretinal abscess due to TB. We went ahead and did the fine needle aspiration biopsy because it was not totally confirmatory of diagnosis. To make a confirmatory diagnosis and to start the patient on anti-TB treatment, this technique is quite safe, and we went to the pulmonary route and went into that mass lesion and took a very small amount of fluid. And this gets sealed up on its own and is very safe. And what we found, gram stain, Giemsa stain, and AFB stain negative, but PCR for IS6110 region and MPB64 region was positive. And we can see that the MPB64 genome and IS6110 gene was positive. So we took the opinion of chest physicians who concurred with the diagnosis, systemic evaluations, commencement of ATT, clearance of the oral steroid, oral prednisone 1 mg per kilogram in weekly tapering dose, oral ranitidine, and oral Shelcal was given. And what has happened to it, and you can see, lo and behold, that this is a complete resolution of the lesions in 3 months period of time. And I will show you the picture in the montage. You can see that the subretinal mass or abscess completely resolved with the steroid and anti-TB treatment. And ultrasonography showed that vitreous pure refractive dot equals retinochoroidal elevation, height was very much reduced, 3.8 mm, basal horizontal 1.6 mm, epidiameter 3.1 mm. Rest of the choroid and optic nerve head was normal. So we have another case of subretinal lesion, and this was the subretinal abscess, and this is due to the tubercular etiology. Is TB need to be considered in this our endemic country like India, affects 1/3 of the world's population, approximately 1.9 billion people in the world is affected with the TB. leading cause of mortality and morbidity worldwide, causing 3 million deaths annually. 8 million people affected annually, 95% of them in the developing countries. And ocular TB occurs in 1.39% cases of systemic TB. So one may not get the systemic TB, but may get that ocular TB with the abscess. So this could be choroidal tubercle, choroidal tuberculoma, subretinal abscess, suprachoroidal abscess, serpiginous like choroiditis, as described from northern India by Professor Aman Gupta and group, retinal vasculitis, like tubercular retinal vasculitis, or we used to call them as Eels disease. We had a publications of intraocular tuberculosis. In fact, the clinico-pathologically proven cases are very rare, and we need to depend on the clinical judgment. Only 5 cases were seen between 1984 and 1994, where we could demonstrate the organisms are bugged in the cell. This is the granulomatous uveitis scleral perforation 1 case, exudative mass in the antechamber 1 case, scleral mass with tiny weight 1 case. We have got a tubercular sclerouveitis masquerade as an ocular tumor, a case report we published, and this was a mass lesions, and the brain also has the lesions, and these particular patients are histopathologically, the eye was enucleated, and histopathologically showed granulomatous lesion as well as the picture produced mycobacterial tuberculosis genome. So choroidal tuberculoma, tubercle continues to grow, location posterior fold, macular or juxtapapillary 4 to 40 mm in size, yellowish in color, subretinal mass with tumor, may have overlying exudative retinal detachment. Subretinal abscess may not be due to TB only, nocardia, Pseudomonas aeruginosa, Streptococcus viridans, Klebsiella, Staphylococcus, non-bacterial cause, Candida aspergillus. So large tuberculoma can liquefaction, necrosis, subretinal abscess, and if you don't treat it, it can lead to the panophthalmitis. So lesion mimicking subretinal abscess, intraretinal abscess, septic retinal cyst, choroidal abscess, amyloid choroidal melanoma. So what test to order? MANTU, 1 HSCT test, PCR of the intraocular fluid, maybe final aspiration biopsy. What is the duration of the treatment? Conclusion, at least 9 months of treatment, antitubercular treatment has been proposed, and this has been proposed by Singapore group of people. Sarcoid, and in conclusion, sarcoid and TB can have protein manifestation. High degree of suspicion to be kept in both the cases in our scenarios, Indian scenarios. Successful resolution can occur if prompt and appropriate treatment can be started, as is shown in these 2 cases. Thank you very much.
Thank you.